Welcome, Dr. Samir Siddiqui. Dr. Siddiqui is Associate Professor of Surgery at St. Louis University and Division Chief of Urology, as well as Interim Chair of the Department of Surgery. Welcome, Dr. Siddiqui.
Thanks for having me.
Dr. Siddiqui, we'd like to talk to you this morning a little bit about the scale which you developed, which has very quickly become adopted throughout the entire country, possibly throughout the world, looking at the acuity of surgery and trying to determine how to triage patients, whether to have surgery during this pandemic or whether to defer surgery. So my first question to you is, what prompted you to create this system?
Yeah, so we were, Missouri's in the middle of the country, and this was mid-March. March 15th actually was the exact date, and we were seeing a fair bit of cases pick up on the West Coast, the East Coast, New York, Washington. We were really in the early phases at that time. We only had one case in the state of Missouri at that time, but the question was coming up, which is, what are we going to do about surgeries once COVID hits the Midwest? I reached out to some colleagues on the coasts and got sort of different answers on what they thought they were doing and what they thought were the best ways to manage this. So at first, this was just an internal exercise. I just wrote it up to say, hey, is this a way to make it work? I sent it to a couple of my chiefs. I said, what do you guys think? And they said, yeah, this looks like it makes sense. And I sent it to ACS. I sent it to Dr. Hoyt that night. And assuming he would just say, yeah, that's an interesting idea. Thanks. We'll let you know if we're interested. But he got back to me pretty quick and said, this is actually worthwhile. And the next day it got published by the ACS. And then I think the day after that, he got back to me and asked me if CMS could adopt it. And next thing you know, it got a pretty wide publication. And I think it worked because, there's two things. It was easy to understand. I think you look at the table, and I think most surgeons can look at it and they can mentally, in their own mind, understand what low, intermediate acuity means in terms of surgery. And I think it also helped for different surgical specialties that were able to adopt it and make their own scales based on this. I think that's kind of why it picked up as quickly as it did.
Well, Dr. Hoyt is very astute at recognizing value inherent in many things, including certainly scales, scores, papers, information, and really hones in. That's one of his many, many talents. And he did have it in our ACS COVID-19 bulletin pretty quickly, and it immediately went to CMS, and as you say, has been widely adopted. It's possible not everybody is familiar with the scale. Could you review it with us in broad brushstrokes and maybe give us one or two clinical examples so that people who are watching this broadcast can understand how to use it?
Yeah, so it's a scale with 3 tiers. Tier 1 is low acuity, Tier 2 is intermediate acuity, and Tier 3 is high acuity. And essentially, Tier 1 cases are cases that are patients that need to have some surgical procedure done, but it's not urgent, it's not emergent, it's not life-threatening. Example of that would be somebody who needs to get surgery for an incontinence procedure. So I'm a urologist, so for me that's an easy example. If you have benign scrotal conditions, a carpal tunnel release, somebody who's had hip pain for several months and needed to get a hip replacement, that's something that would fall into Tier 1. I'll jump to Tier 3 because that's an easier one to explain. So Tier 3 is an elective case, but you really can't delay it. And so a lot of our cancer cases fall into that. Certainly cancers that cause organ dysfunction. So if you have jaundice from a pancreatic cancer, that really shouldn't wait. If you've got organ dysfunction from a small bowel obstruction from an advancing malignancy, that really can't wait. Those tend to fall into Tier 3s. If you have a coronary artery disease and you've got angina and PCI can't manage it and you're symptomatic, that probably can't wait. A large AAA. So those fall into Tier 3, and everything else is in between, and that's Tier 2. That's sort of the gray area. Patients who may have ureteral colic, where they're having pain from a stone, symptomatic, needs to be managed, but probably doesn't need to go to the operating room immediately, is sort of a classic example in my mind of a Tier 2 case. So that's the big picture view of this scale.
And now that we're, I think, exactly 1 month into using your scale, are there any changes that you think you might introduce?
I think one lesson we learned early on from the scale was the initial publication of the scale outlined the option to use ambulatory surgery centers with tier 1 cases and some tier 2 cases. And I thought at the time that, you know, if we can get some of those low acuity cases out of the hospital and away from COVID patients, that would make sense, and those patients still get the care they need. But once the pandemic started to pick up, and we're up to 4,000 cases now in Missouri, it became quite clear that even those cases had to wait. And so I think the ASC option made sense sort of very early pandemic, depending on what region you're in. But really, it fell out of favor, appropriately so, once the cases really started to pick up. I think going forward, we're working on a new version because I think we need to start thinking about sort of once we pass our peak, and some areas have passed their peak, and things start to settle down, what is that going to look like for elective surgery? How are we going to scale that back up? How are we going to get busy again? I'm sure you have surgeons, and I have surgeons who want to be busy and want to start getting back into the operating room as quickly as possible. So the new scale we're working on is going to include ASA classification. So we want to really get anesthesia involved in helping us determine whether or not we should be putting the sickest patients into the hospital right now, and whether or not that's a good idea. So that's a new point of discussion. Whether or not the patient's going to need an intensive care unit bed. You know, a lot of our ICUs around the country are full right now. We're close to full. And if we're going to do elective cases, do we want to do cases that use an ICU bed or not? I think is going to be a major question as well. And then the last really big one is COVID testing, or just testing in general. How is that going to fit in over the next few weeks to few months with elective surgeries? You know, are some patients have had COVID? Should we do serologic testing on them? What's the quality of the serologic testing? I think we're still a little bit of a ways away from that. And then the really high risk patients, should we get COVID testing on them before surgery? Unanswered questions right now, but I'm sure actively being discussed among, you know, department chairs and leadership around the country right now.
Yeah, and those are all very important points. It's a rapidly evolving field, and clearly you're adapting to it. And I commend you for that evolution and that flexibility on a rapid basis. One other consideration I didn't hear you mention, and perhaps it's not part of the acuity scale, is the availability of PPE in an institution. Is that a consideration?
100%, absolutely. I think that's a major consideration. And I think if we're going to be looking at starting to do those tier 1 and tier 2 cases again, especially in an ASC model, I think making sure that region has, that hospital system has adequate PPE is absolutely essential. And you really, I think, want to be on the downward end of the curve where your PPE utilization is already going down before you really start scaling up those other cases. So the answer is yes, absolutely.
Although the type of PPE would be impacted by the availability of testing and the accuracy of testing. So if you knew somebody was definitively negative, if that were possible, you wouldn't need the same PPE requirements as you would if you knew someone was positive.
Absolutely. Another major reason why testing needs to be part of the algorithm, because it will adjust our PPE utilization.
Yeah, 100%. Now, do you have any efforts underway to validate, I suppose validation is the wrong word, but at least to track the outcomes? Like if you have somebody who retrospectively in review, you say, I wouldn't have put that patient in a category 3, I would have put them in category 2. Was there an adverse outcome by waiting? Or conversely, here's somebody could have been 2, but we put them 1 and they got operated and then they acquired COVID or had an adverse outcome. Are you looking at those, tracking those data?
Yes. So we've just started a process where, at least on the elective surgery side, I have asked my surgeons to start putting the tier into the surgical scheduling form. So we actually know ahead of time. And so we're looking at that retrospectively just to see how surgeons are tiering cases. We're still kind of not really quite at the peak of our surge right now. So there's not a lot of tier 1 or tier 2 cases happening right now. So I think once we're past that peak and you start seeing all the tiers being used again, then I think it's going to be really useful. And I think that, we do need to look at that.
Oh, so while you're not doing a lot of tier 1 and 2, but yet obviously you're not doing tier 3, are your surgeons being retrained to do other things? For example, what are the urologists being trained to do?
Yeah, so they're being encouraged to write papers and be academically productive. We do have a surge plan in place. So I do have my trauma surgeons as backup to our intensivists. Our urologists are on board to provide first assist support for our ACS call. So I have figured out ways to put people in different places to manage the surge. But I wouldn't be lying to you. There definitely are surgeons here and around the country that could be busier but aren't because of this crisis.
Sure, absolutely understandable. Are there any other facets of the acuity scale or the COVID pandemic at your hospital you'd like to share with us?
I think we hit the big points. I do think it's worth mentioning that big picture. I think as surgeon leaders, we need to think about how do we plan for future pandemics. I think most of us would agree that we weren't, quite prepared for it, and I don't blame anybody for it. Nobody saw this coming. But I think I wouldn't be surprised if we see another zoonotic spillover in the next 10, 15 years, and another organism comes around. And how do we do a better job next time this happens, so that we're a little bit more prepared? Maybe we'll do a better job with PPE reuse and have a more formalized process there, or maybe we'll do a better job with ICU cohorting. But I think there are things that as surgeon leaders we should be thinking about, because I'm not sure if this is the last time we're going to see this, and I think we should be thinking about that.
Well, I thank you for your reflections, and I congratulate you upon coming up with what, at least during my career of 3 or 4 decades, is probably the most rapid ascension from back of napkin to adoption by the federal government that I've ever heard. So congratulations on that meteoric success of your acuity scale. We look forward to reading your publications and hearing your lectures about how it's all worked out in the future. And in the meantime, wish you and your department and your loved ones a safe, healthy outcome at the end of it.
Thank you very much. Thank you for the opportunity.